What up all my two doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to continue with our CVS series, the Cardiovascular System series, with our second lecture with Antihypertensives and Diuretics. It's written and created by Dr. Kanan Shah, presented by me, Rishi Shah. So, before we begin, just a little heads up, this is a very dense topic and a very lengthy one. So, stay tuned, get your notes and papers out, and here we go. Today we're going to cover hypertension overview, which we ended the previous lecture with. We'll take a look at the etiologies of hypertension, moving on to the mechanisms of BP control. Now, majority of this is going to be a review of physiology. Then we'll move on to the pharmacology aspect of it, where we classify hypertensives, the agent, the drugs. Then we'll take a look at all of them in extensive detail, as this is an extremely important chapter in dentistry, as well as medicine and other paramedical subjects. Diuretics is now in extended detail, so we were going to create two different lectures for each. However, we mixed it together as they overlap in concepts a lot. So this should be a very concise, however, a lengthy lecture for you guys. Hypertension emergencies discussed, and then resistant hypertension as a short note, and we'll review the entire topic today, and then of course references. So just to kickstart the day, I know it's a long lecture, so with a little joke. Middle-aged men have a higher predilection for being diagnosed with hypertension. It's a fact. But I wonder why. Just kidding, guys. So let's move on. What's hypertension? Well, it's sustained increase in systolic blood pressure above 140 and sustained increase in diastolic blood pressure over 90. The term sustained is very important because otherwise it could be classified as white coat hypertension. For example, if it's not sustained and you visit the doctor, so in the presence of the doctor, a blood pressure reading is, say, 140 over 90, then it's not hypertension. It's known as white coat hypertension. So sustained is important. So diagnosing the patient with hypertension, we must record a blood pressure of 140 over 90, whichever value comes first. So we're not looking for 140 and 90. This term or is very important. So what are the physiological causes? By physiologic, which means what does our body have to do with increasing the blood pressure? We have increase in peripheral vascular resistance, increase in smooth muscle tone, which means vasoconstriction. Renal artery constriction. Now remember, kidney has a lot to do with maintenance of the cardiovascular system. We'll get into the details of that. Pheochromocytoma is a tumor in the medulla in the brain. Aortic contraction, that's the heart itself. Hyperthyroidism, and we will discuss a lot about this in our medical management series of medical compromised patients, and Cushing syndrome. Two types of hypertension. There's primary or essential without any etiology, that it just appears. Secondary is there is an actual etiology, a cause which led to hypertension. And of course, white coat, which is increase of blood pressure in the presence of a doctor. Hypertension as a risk factor. So whenever hypertension is present, we are worried that there will be a concomitant disease that can occur, such as stroke, also known as cerebrovascular accident, angina and MI. We have CKD and CHF. CKD, sorry, it's hidden down here. CKD is chronic kidney disease. Again, kidney has a lot to do with our cardiovascular system, and congestive heart failure, which is CHF. Now, just a little overview on the chart. We'll, of course, take a deeper look this time to this chart. Systolic and diastolic. If we want to know what these terms are, please take a look at this link here. It's the video to our cardiovascular overview. Moving on to normal blood pressure. Now, normal is not 120 over 80. It is less than 120 and less than 80. Because as soon as a value touches 120 or 80, it's now considered pre-hypertension. So let's keep that in mind. It goes all the way up to 140, so 139. But as soon as 140 is involved, we are now at stage 1 hypertension, remember? Sustained increase. And then we have stage 2 with over or equal to 160. This is systolic. Diastolic, again, less than 80 is normal. 80 to 89 is hypertension prior, so pre-hypertension, no, not diagnosed yet. As soon as the value of 90 touches, which is here, it's now considered stage 1 hypertension. Up to 99, because after 100, including 100, it's stage 2 hypertension. So if we think about it, do you notice a pattern here? That in systolic blood pressure, we're increasing by almost 20. There's a pattern, right? So 120 is right here in pre-hypertension. It's 140 in stage 1. It's 160 in stage 2. Similarly, in diastolic, we're increasing by 10 values. So 80 to 90, 90 to 100. So it's just a trick to remember when we're actually looking at exams. But you know what? By the end of the lecture, you'll remember the values very well. So hypertension etiologies. Essential hypertension is basically no identifiable cause, also known as primary hypertension. And 90% of the patients that are diagnosed with hypertension are having essential or primary hypertension. But secondary hypertension is more intriguing because it has a known cause, an actual physiologic cause that leads to hypertension. It's a condition or a disease that contributes to diagnosing hypertension. So diseases such as diabetic nephropathy. Again, remember it has to do with kidney. So diabetic nephropathy. Then polycystic kidney disease, another kidney. Glomerular disease, another kidney, and renal vascular hypertension, another kidney disease. So when we're talking about systemic, we're going to involve a lot of kidney when it comes to the heart. Perfect. And conditions. So this was diseases, and this is conditions. Conditions such as Cushing syndrome, which is too much cortisol. Aldosteronism, too much sodium retention in the body. Pheochromocytoma, caused by too much epinephrine release. And remember, epinephrine is a vasoconstrictor. Remember? Vasoconstrictor. Therefore, its effect on blood vessels, like this one, is extremely high, leading to hypertension. And then we mentioned hyperthyroidism, which is too much thyroid hormone. The risk factors for hypertension, which are either modifiable or non-modifiable, are obesity, familial pattern, genetics, sedentary lifestyle, diet high in sodium, diet low in potassium, tobacco use, alcohol abuse, older age, male, and racial patterns. So all of these are a comprising of both modifiable, such as obesity or sedentary lifestyle or diet. These are modifiable, whereas familial patterns and genetics are not modifiable. Age is not modifiable. Gender is not modifiable. In resistant hypertension, blood pressure that remains elevated even after 3-drug regimen including diuretics, that's resistant hypertension. So 3-drug regimens including diuretics, still blood pressure remains elevated, it's hypertension, known as resistant hypertension. Contributing factors. We have alcohol, poor compliance of medication, comorbidities such as diabetes, sleep apnea, or other uses of medications such as sympathomimetics and long-term NSAID use. So just as a side note, that any patient who is taking NSAIDs, right, for example, aspirin or ibuprofen, then our job is to limit it to 4 days of use. Otherwise, it will not be the first choice. Okay, so just a little side note for your notes, that whenever a person is diagnosed with hypertension, we do not want to continue NSAID use for longer than 4 days. Now, speaking of dosages, one more, sympathomimetics or epinephrine. We want to limit the epinephrine dose down to 0.04 milligrams. This is the limit for a patient who has any cardiac condition, such as hypertension. Otherwise, you can give it all the way up to 2 milligrams of epinephrine. This is a calculation for local anesthesia, and of course, you'll find the link to our video and local anesthesia calculations above here. Moving on to factors that affect blood pressure. Now, we mentioned this, so it's going to be a quick slide. Non-modifiable factors are age, gender, genetics, and ethnicity. Modifiables are obesity, salt intake, which is sodium, potassium intake, fats, alcohol intake, smoking, stress, physical activity, and socioeconomic status. I know it's very weird how this is a correlation, but it's a part of the list from our references. Prevent any cardiovascular and renal morbidities and mortalities. So our job is to take care of any renal and cardiovascular morbidities and mortalities. Prehypertension is a threshold to decrease blood pressure by lifestyle education. So main is the sedentary lifestyle needs to be corrected. And then, of course, conjugated with medications if there is a threshold that is surpassed. The goal of blood pressure for any hypertensive patients in medical is below 140 systolic and below 90 in diastolic. So they will remain, say, in elevated or pre-hypertension, but they will never have stage 1 or 2 hypertension, considering we take care of all of these factors above. Now, remember when we said that there were some concomitant diseases with hypertension patients? Well, these are the diseases, and the blue line dictates how many percentages of hypertensive patients have these diseases. So it lets us know which is the most prominent, right? For example, angina, MI and angina. That has a lot to do with hypertension. Look at that, 15% of hypertensive patients can suffer angina or have suffered angina. Diabetes, very high. Hyperlipidemia, of course, high. It causes hypertension. Heart failure is way up there. And then comes previous history of MI, renal impairment, and asthma, which can also lead to a comorbidity factor of hypertension. Moving on to the mechanism of blood pressure controls. Our body has a way to control blood pressure. See, arterial blood pressure, that's one term we need to know. It is directly proportional to cardiac output and peripheral vascular resistance. What does that mean? Amount of blood that heart puts out versus amount of resistance our vessels have, that is directly proportional to blood pressure. So if cardiac output goes up, blood pressure goes up. If peripheral vascular resistance goes up, blood pressure goes up. Very simple. Okay. So cardiac output, it's completely based on cardiac muscles, and it's in the control of the beta-1 adrenergic receptors. PVR, peripheral vascular resistance, have to do with peripheral vessels, arteries, nerves, vessels, capillaries. Control of alpha-1 receptors. So, one pattern noticed here, that anything to do with blood pressure has to do with adrenergic system. And again, we have a lecture already detailed for adrenergic system up here. Please go visit and revise that for how beta-1 and alpha-1 affect blood pressure. However, this is important because epinephrine, being a vasoconstrictor, acts on both of them. And that leads to our previous slide's note that epinephrine being a factor for hypertension. Arterial blood pressure, this is from our references, will work upwards. So when there's blood volume and venous tone, we have heart filling pressure. Whenever there's increase in blood volume or increase in venous return, our heart fills much more. When that happens, it has to contract even more to get rid of that blood and out to the body. Hence, it increases heart rate. Whenever these are put together, we have a value known as cardiac output. When that is proportional or multiplied by peripheral vascular resistance, which means the blood that is flowing out of the heart is resisted against the arterial tissues, then we have something known as PVR, peripheral vascular resistance. Proportionally multiplied leads to blood pressure. That's the simple formula. Perfect? Mechanism of blood pressure control. So, Our body controls it in two ways. It uses something at the top floor of the body, which is the brain, and the bottom floor, the basement of the body, which is kidneys. So think of it this way. Heart is in the middle of it. It gets controlled by brain and kidney. Baroreceptors are part of sympathetic nervous system, the autonomic nervous system, that the brain dictates to control the blood pressure, whether up or down, depends. And baroreceptors are actually these chemoreceptors in the body that pick up signals that tells the brain to increase the blood pressure or decrease it. Renin-angiotensin-aldosterone system, it's through the kidney. Lots of this has to do with blood volume that leaves our body. So we'll get into extreme detail about it, so hang in there with me. Baroreceptors, they act directly on the sympathetic nervous system. And again, sympathetic is adrenergic, right? A lot to do with increase or decrease in blood pressure. Rapid moment-to-moment blood pressure regulation. So baroreceptors have extremely good sensitivity. As they're located on aortic arch and carotid sinuses, they will detect changes in the blood vessels, blood flow, muscle tone, and all of these little details and data. It will then transmit the data to the brain. So let's see how it works. Low blood pressure will trigger baroreflexes. By the way, baro means pressure. This will increase the sympathetic and decrease the parasympathetic tone. Then this causes vasoconstriction in the vessels and increases cardiac output. So vessels, alpha 1. Cardiac output, beta 1. All of this is controlled by sympathetic or adrenergic system, which is done by epinephrine or norepinephrine on both ends of the adrenergic system. Very simple. RAS acts directly on the kidney. Long-term blood pressure regulation by blood volume. So it's an actual physical blood volume detection. It's located on beta 1 receptors on the heart and baroreceptors in the kidney. So again, kidney dictates how much blood volume to conserve, how much to let go. How? We'll take a look at that. Low blood pressure and low sodium triggers the increase in renin release. So that's the renin-angiotensin. So renin release. Renin then converts angiotensinogen to angiotensin 1. Angiotensin converting enzyme does this to angiotensin 1 to angiotensin 2, and this causes vasoconstriction in the blood vessels. Wow. So this was a very oversimplification of the process. We will take a look at how that works. But for now, let's write down these steps in our notes so we're used to the terms: angiotensin, angiotensinogen, converting enzyme, renin. These words will come up in the next few slides. The mechanism of blood pressure control. Where is renin? The kidney controls renin, it originates renin, and its job is to convert angiotensinogen to angiotensin 1. Okay, let me break this down for you. Any word that you see with ogen or nogen, angiotensinogen, this is inactive. Okay, let's write that down. Angiotensin 1 is the first model of an active angiotensin. Okay, so angiotensinogen 2, first active molecule, which is angiotensin. Okay, where is angiotensin converting enzyme found? It's found in the lungs and in the kidneys. It converts the first model of angiotensin to the second model of angiotensin. Okay, first model to second active model. So it's a two-step method, and that is done by ACE, angiotensin converting enzyme. Okay, so what's the role of angiotensin 2? Remember, this is the second model. Well, why is the second model so important? First of all, we need to understand that everything works with molecules acting on receptors. So the receptors responsible for any angiotensin 2 actions are known as angiotensin receptors, specifically the type 1 receptors. So angiotensin type 1 receptors. This is important for drugs. Okay, so remember this, that any angiotensin 2 acts on angiotensin type 1 receptors. Okay, what do they cause? It causes direct vasoconstriction of arteries and veins. It causes increase in glomerular filtration, GFR. It increases in the kidney. Kidney goes in hyperfunction, leads to stimulation of aldosterone secretion. Aldosterone is a mineralocorticoid, which leads to an increase in renal sodium reabsorption, so increase in sodium in the body. And you know what happens when that happens? There's an increase in blood volume. Because of increase in blood volume, there is an increase in cardiac output, and we know what happens when cardiac output is increased. Blood pressure increases. Fair enough? That's the power of angiotensin 2, the updated model. Okay, let's bottleneck. Remember, at Tooth Factory, we teach bottleneck. We go from very general to very specific, and bottleneck is here. Okay, here we go. Liver. The origin of angiotensinogen is an inactive molecule produced by the liver. The kidney produces renin. Okay, renin goes and converts this inactive model to angiotensin 1 model. Angiotensin 1 is really not that useful, but an enzyme produced by the lung, known as angiotensin converting enzyme, will convert the first angiotensin model to the second angiotensin 2 model. Now we have angiotensin 2. That angiotensin 2 is the powerful molecule that acts on the kidney itself at the adrenal gland and leads to aldosterone production. Aldosterone leads to reabsorption of sodium chloride and water, increase in blood volume, increase in cardiac output, increase in blood pressure. Simple. The other aspect that angiotensin 2 acts on is direct vessels, causing vasoconstriction. Vasoconstriction increases PVR. Increase in PVR causes blood pressure increase. Very, very simple. Hopefully this diagram is now better. I know I'm going slow, but this is very important, guys. So let's understand this from a different perspective. RAS, again, extremely important for our science here. Liver produces angiotensinogen, inactive, terrible, useless, right? But some factors, such as low blood pressure, low cardiac output, low PVR, or when the body or the kidney detects that there is an increase in the sympathetic autonomic nervous system, that, oh, why is the brain working so hard? Why is the adrenergic system activated? In that case, stimulation of renin occurs. So the kidney produces renin. Renin converts this inactivated angiotensinogen to the first model of angiotensin 1. Angiotensin 1 is also kind of useless. It has nothing to do with the blood pressure. So the lungs produce angiotensin converting enzyme that makes the powerful angiotensin 2, the second updated model. And that leads to action on several body parts, such as on the kidney. It constricts the glomerular filtration, which means it increases aldosterone effects, sodium water exchanger effects, which means there is increase in retention of water, increase in blood volume. On the posterior pituitary gland, we have antidiuretic hormone that is secreted, which means its job is to increase water retention, sodium water retention, increase in blood volume, increase in blood pressure. Also, it directly occurs on vascular smooth muscle, causing hypertension directly. Hypothalamus is also stimulated, and therefore it stimulates thirst because it holds water. Adrenal cortex. Adrenal cortex is affected directly on the kidney, leading to aldosterone secretion. Again, it has to do with blood volume increase, causing a flip of all of these. Okay? Perfect. That is RAS. Now, this is what baroreceptor does. So we talked about RAS, right? So when we go back to this slide here, when we were talking about the two types of systems, We just talked about RAS. Now we're going to talk about baroreceptors, okay? So let's go back to the slide here with me. Baroreceptors. This is the brain stem and the spinal cord junction, okay? There's a series of action that takes place. For example, when there is baroreceptors in the carotid sinus, by carotid sinus we mean this is the external carotid artery, this is the area of the neck where carotid sinus rests, okay? So this is what happens. Baroreceptors gets activated. After that, a sensory fiber sends an inhibitory interneuron to nucleus tractus solitarius located in the brain stem. That then tells a vasomotor sensor to activate an impulse that goes to the autonomic ganglia through the spinal cord, after which motor fibers gets activated, and motor fibers then go and affect blood vessel walls to increase sympathetic tone. And by sympathetic tone at blood vessels, what do we mean? We mean alpha and beta receptors, specifically alpha 1, beta 1. When they're activated, we have increase in blood pressure. So if there's low blood pressure, there's less impulses to the CVS by baroreceptors. The brain goes, why is there less impulses being sent by baroreceptors? Then the brainstem says, uh-oh, we need to increase sympathetic and decrease parasympathetic nervous system activity. Leads to vasoconstriction, increase in cardiac output, increase in blood pressure. That's what baroreceptors do. Okay? Baroreflexes are part of sympathetic nervous system. There's rapid regulation of blood pressure, whereas RAS, the kidney, was long-term regulation of blood pressure. Location on aortic arch in the heart, and carotid sinuses in the blood vessel. Okay, so the body has a lot of mechanisms set in place. And this is a summary of both together, baroreceptors and the RAS system. If there is decrease in blood pressure, then there is increase in sympathetic activity in the autonomic nervous system. That leads to the activation of beta 1 receptors on the heart. Leads to increase in direct cardiac output, increase in blood pressure. When there is increase in sympathetic nervous system activity, there's also increase in the alpha 1 receptors on the vascular smooth muscles. That leads to two actions, increase in peripheral vascular resistance and increase in venous return to the heart. In both cases, we have increase in blood pressure. This is what sympathetic autonomic nervous system does on the commands of the baroreceptors. Clear? Okay, so let me erase this pen off the paper. When there is decrease in blood pressure, what happens in the kidney? We have renal blood flow reduction. The kidney goes, oh, I have low renal blood flow? Well, let me introduce renin, because I have to increase my renal blood flow. So renin goes up. Renin goes up, and that means angiotensin 2 goes up. Remember, the whole RAS system invests in here. And we know that angiotensin 2, the powerful power pack, is going to increase direct peripheral vascular resistance in the blood vessels, leading to increase in blood pressure. Along with that, it's going to increase aldosterone. When aldosterone is increased in the kidneys, there is increase in sodium water retention, which increases blood volume, which then increases cardiac output, leading to increase in blood pressure. That's why we call angiotensin 2 a power pack molecule. Again, decrease in renal blood flow also has to do with physical kidney activity. It reduces the GFR of the kidney. That also increases sodium water retention and, of course, increasing blood pressure eventually. Okay? Very, very smooth and easy concept to understand. Now we're moving into the antihypertensive classification. These are all the drugs associated with hypertension. There's a diuretic classification. There's the ACE inhibitors, angiotensin converting enzyme inhibitors. Angiotensin 2 receptor blockers. Remember the AT1 receptors that we were talking about? That's this. There's renin inhibitors. There's calcium channel blockers, beta blockers, alpha blockers, and other. All of these drugs are extremely important, okay? And we'll talk about them in detail ahead, However, this chart is good to understand with a pattern. So what kind of patterns? Take a look at this. ACE inhibitors, ACEI, they're all going to be prils. Okay, all prils. Pril. Angiotensin II receptor blockers are all sartans. Fair enough? So these are sartans. Calcium channel blockers are all dipin. Dipin. So CCBs are all dipins. Beta blockers, olols. So beta blocker are all olol. Okay? Alpha blockers, zosin. Zosin. And others. So now we have remaining diuretics and others. In diuretics, there are some drugs that are very, very important to remember. That includes amiloride, chlorthalidone, furosemide, hydrochlorothiazide, and spironolactone. Very important, and we must know these by heart. And again, at the end of the lecture, you will. So don't worry. Other drugs, clonidine, methyldopa. If you don't remember the whole list, no problem. But clonidine and methyldopa, extremely important to remember. Okay? So as soon as we hear the suffix of all these drugs, we can recall that these are antihypertensives and they are from a specific class. Okay? This is a chart from our references that shows that treatment of hypertension in patients that have another disease present, right? For example, concomitant disease of high coronary disease risk, which is, say, angina or MI, for example. In that case, we would give diuretics, beta blockers, ACE inhibitors, and calcium channel blockers. This is with hypertension, so plus hypertension. If it's just diabetes, then we give diuretics, no beta blockers, we give ACE inhibitors, we give angiotensin II receptor blockers, and calcium channel blockers. In recent or recurrent stroke, we would give diuretics and ACE inhibitors, and not calcium channel blockers. Heart failure. In heart failure, we give diuretics, beta blockers, ACE inhibitors, ARBs, aldosterone receptor antagonists, and so on and forth. And we have previous MI infarction. In that, we don't give diuretics. We give beta blockers, ACE inhibitors, and aldosterone receptor antagonists. In chronic renal disease, no diuretics. Beta blockers, not needed. ACE inhibitors and ARBs, for sure. So that's how we can decide the treatment modality. Now, why is this chart important? Well, you could get a question in your exams saying that this person has these two diseases, what drugs to be given? In that case, we could write that, for example, heart failure, you can give every drug possible, all classes of drugs. So heart failure is easy to remember. Then the other thing that's easy to remember is chronic kidney disease. If there's a chronic renal disease patient with hypertension, then we will not give diuretics, right? Because we don't want the kidney to hyperfunction when it's already having troubles. Therefore, only ACE inhibitors and ARBs, nothing else. The least. So the most and the least, very easily remembered. Now let's talk about recurrent strokes. In that case, it's easy to understand that diuretics can be given, no problem. ACE inhibitors, they're actually given in all diseases, so one of the most common medications, for sure. But why aren't we giving beta blockers? Why aren't we giving calcium channel blockers? Well, think about it. If there is a stroke and we give beta blockers, then the blood flow through the heart is impeded. We can't afford that. Yes, we can deal with kidney, no problem, but direct blood flow, not a useful choice. What about calcium channel blockers? What are they? They're vasodilators. Person with a stroke, do you want vasodilation? No, we do not. Otherwise, blood flow to the brain will go extremely fast, extremely high volume of blood will go, and it will lead to stroke again. Therefore, in recurrent stroke, kidney, okay to deal with, but direct heart and direct blood vessels, not okay to deal with. That's how we can understand concomitant diseases. Okay. Moving on to the diuretic action on the nephron. So we're diving in even deeper. This is the route through which various different ions pass through our kidney and excrete themselves out. So to understand this whole thing, we need to understand these number 1 to 5 structures. See, this is known as the Bowman's capsule. Okay? It's part of the kidney. Bowman capsule. This is where all the fluid from the blood vessels, the capillaries, gets exchanged. When they come to the Bowman's capsule, there is something called as a filter, glomerular filter. This determines the GFR. Okay, the GFR. It first passes through the proximal convoluted tubule. Then that fluid moves down the loop of Henle, so descending loop of Henle, and then moves up the loop of Henle to ascending loop of Henle. Then moving on to distal convoluted tubule, right? So proximal, distal. After which it leaves the body as it goes through collecting tubule and collecting duct. So why is this all important? Well, this is important because not only sodium and water gets exchanged, but various different ions gets exchanged, which means we must, as a part of pharmacology, we must design drugs for each different level of kidney. Okay? We can't have just sodium water retention. We can't just have other molecules leave the body. So certain diuretics act at certain locations, and that helps us understand the physiology. So acetazolamide, for example, is a drug that affects proximal convoluted tubule. Thiazide and hydrochlorothiazide affect the distal convoluted tubule. Similarly, no drugs affect the descending loop of Henle. The ascending loop of Henle is affecting the furosemide. These are known as loop diuretics. Obvious reasons, ascending loop of Henle. That's why it's known as loop diuretics. Then comes collecting tubule and collecting duct. We have spironolactone, amiloride. These drugs affect the collecting ducting tubule. Well, why are they important? Well, acetazolamide at the proximal convoluted tubule does this. A carbonic anhydrase inhibitor that inhibits the reabsorption of carbonate ions in the proximal convoluted tubule. So what does it do? This drug acts on proximal convoluted tubule as a carbonic anhydrase inhibitor that inhibits the reabsorption of HCO3. So it lets HCO3 out of the body, not inside the body, out of the body. It lets it pass through the loop of Henle and out the body. With HCO3, water will follow, other molecules will follow, but it's not sodium, right? So it's not as strong. So it's a weak diuretic property. Okay, that's acetazolamide. Then we have thiazide and thiazide-like drugs, which are hydrochlorothiazide. They work on distal convoluted tubule. They inhibit the reabsorption of sodium chloride in the distal convoluted tubule, resulting in retention of water in the tubules. Most commonly used diuretics in the treatment of hypertension. So this tells us that it inhibits the reabsorption of sodium into the body. It keeps the sodium and chloride in here. That allows water to remain in here. It follows, right? Now, just as a little reminder, why do we want the water, sodium, and chloride to remain in the kidney's route and leave the body? Well, think of it. Hypertension has to do with a lot of sodium and chloride in the body over here. So antihypertension will throw away that sodium chloride, followed by water out the body, decreasing the blood volume in the body. That leads to decreasing cardiac output and works as an antihypertensive. Okay, is that mechanism fair? We'll discuss it in detail ahead. So therefore, it's the most commonly used diuretic for treatment of hypertension because it directly affects sodium and chloride. Let's talk about loop diuretics. Now these are dangerous. These are potent, very, very angry drugs. The loop diuretics inhibit the sodium, potassium, chloride cotransport into the ascending loop of Henle, resulting in retention of sodium, chloride, and water in the tubule. So not only does this affect on sodium and chloride, it also affects on potassium into the tubule, having it leave the body. Perfect? These drugs are most efficacious in the diuretic category, which means they're the most potent. Potent is the word. Okay? Let's talk about spironolactone. Before we do, I really need you guys to understand one thing. So far, what do we have? We have HCO3 leaving the proximal convoluted tubule towards descending loop of Henle. So far, there is no mentioning of sodium water retention, right? So far we have sodium in the body being absorbed. Fair enough? But HCO3 is being let go of. As we move through the ascending loop of Henle, that sodium is no longer reabsorbed and is thrown into the urine with potassium and HCO3. Fair enough? Everything is in the urine, no longer in the body. Okay? Distal convoluted tubule occurs, and all of a sudden, sodium and chloride have a worse effect. They can no longer enter the body. All of these molecules are also leaving the body towards urine. But now we have spironolactone, amiloride. What are these drugs? It's an aldosterone antagonist that inhibits aldosterone-mediated reabsorption of sodium and secretion of potassium. What does that mean? It inhibits the secretion of potassium. Amiloride blocks sodium channels. Wow. Look at how our body works this. What did we need to get rid of to decrease blood volume? We need to get rid of sodium and water. Perfect? Not potassium. So our body at the collecting tubule duct reacts to spironolactone and amiloride, and it throws away sodium, chloride, water, HCO3, but it prevents the secretion into the urine of potassium and brings back potassium into the body. Out comes the urine, and we have prevented the loss of potassium that occurs with thiazide and loop diuretics. Imagine that system. How beautiful is that? Therefore, we don't have any adverse effects of potassium. Sodium, chloride, HCO3, water, leave us in the urine. Blood volume decreases, blood pressure decreases. Fair enough? Awesome, look at that. How easy was that, guys? Okay, now let's take a look at this from our diagrams. The blue arrow is reabsorption into the body. Keep that in mind. The red arrow is secretion into the urine. Okay, now before we move ahead, I want to make sure this is understood. This is regular body function. Okay, this is regular body. It's not about pharma. Okay, this is regular body's function. Normally, organic acid and base secretory system will secrete a variety of organic acids into the proximal tubule from the bloodstream. This is normal body function. Ions come into the kidney. In the proximal tubule, we have sodium, potassium, water being reabsorbed normally into the body. We have ascending loop of Henle where sodium, potassium, and chloride gets absorbed into the body. In the distal convoluted tubule, we have chloride and sodium being reabsorbed into the body. In the collecting tubules and duct, we have sodium being reabsorbed into the body, while potassium gets secreted into the urine through the means of aldosterone. Water gets reabsorbed into the body from collecting tubules and duct using antidiuretic hormone. But here's the trick. This is regular body's function. As soon as we give drugs like acetazolamide, then this gets prevented. All of this reabsorption gets prevented and comes out in the urine. As soon as we have loop diuretics such as furosemide, then we have the ascending loop of Henle not functioning. Therefore, sodium, potassium, chloride leaves the body into the urine. As soon as we have thiazide-like drugs affecting the distal convoluted tubule, then it stops working and sodium and chloride gets excreted into the urine. And as soon as we reach collecting tubules and we use amiloride or spironolactone, then we have potassium being saved into the body and sodium and water being thrown out the urine. Perfect? So this entire slide is so important, guys, that in the normal function of the body, this happens, and using certain medications, we can block the action of those parts of the body, the kidney, leading to a change in blood pressure. That's how diuretics work in a nephron. Hopefully this is easy to understand, guys. Okay, now let's dive in deeper. Two important drug groups of diuretics. We have thiazides. What's the mechanism of action? It's going to be very simple and quick in this scenario. It affects the ascending loop of Henle and distal convoluted tubule more than other parts of the kidney. It decreases the reabsorption of sodium by inhibition of sodium chloride cotransporter. It increases tubular concentration of sodium chloride, therefore it can be passed through urine. The excretion of these ions in the urine helps decrease blood volume. Remember, it's an antihypertensive, right? A diminished kidney function, such as in chronic kidney disease, it prevents this action. Thiazides will decrease efficacy, may decrease efficacy when used with NSAIDs such as indomethacin. They reduce renal prostaglandins. Remember, prostaglandin blockers are NSAIDs, and therefore they reduce renal blood flow. So with CKDs, thiazides are not preferred. What's the pharmacological action? Ultimately, the increased sodium and chloride excretion will lead to hyperosmolar urine, a loss of potassium, as well leading to hypokalemia, a loss of magnesium ions, which is magnesuria. It promotes reabsorption of calcium ions, preservation of bone density in the hips. This is one effect that we need to understand as well. Loop diuretics work opposite when it comes to calcium. Okay, another important point to understand, very important. Reduced peripheral vascular resistance by reducing blood volume, leading to a reduced cardiac output, leading to blood pressure reduction. It induces vasodilation as well. Not sure how, but it induces vasodilation. Ultimately, blood pressure reduction. So, all in all, guys, remember this point about calcium. Okay, very important. We'll come back to this during heart failure lecture. Okay, moving on. How do thiazides work in our diagrammatic form? This is relative changes in the composition of the urine induced by thiazides. There is decreased urinary excretion of calcium. Remember from our previous slide. Increased urinary excretion of sodium and potassium in the urine versus loop diuretics. Now this is opposite for calcium. It increases urine excretion of calcium. See that difference? Very important. And of course, sodium and potassium are also excreted. If you notice, we mentioned that there is an increase in potency when it comes to Loop diuretics, right? Well, think of it this way. The thiazides have a certain volume of urine that is excreted to reduce blood volume. But loop diuretics have a much larger reduction in blood volume. Therefore, they're more potent. So this diagram, note it down, guys. It's extremely important. Okay, therapeutic uses. When should we use thiazides? Treatment of hypertension, mild to moderate essential hypertension, because we have no etiology. Treatment of heart failure. Loop diuretics are better here because they're more potent, but thiazides can help as an adjunct if given 30 minutes prior to loop diuretics while treating congestive heart failure. Treatment of hypercalciuria. Remember, in calciuria, it's a condition where there is increase of calcium in urine. In that case, thiazides can help. Remember, because they decrease the urinary excretion of calcium. Therefore, it can be used in the treatment of hypercalciuria. It's thiazides that inhibit the urinary excretion of calcium ions. Treatment of diabetes insipidus. It's uniquely producing hyperosmolar urine. That's why it can be used in the treatment of diabetes insipidus. Remember, it's not mellitus, it's insipidus. It's diabetes caused by various ion retention in the body. Okay, not a part of our syllabus, so don't worry about the whole chapter of diabetes insipidus. Pharmacokinetics. Thiazides are effective orally. 1 to 3 weeks duration, needs to be used for stable reduction in blood pressure for a hypertensive diagnosed patient only. It's got a high and an extended half-life, which is really, really good. Okay, so thiazide side effects. We have fluid and electrolyte imbalances, so therefore dosing is extremely, really important for doctors. Hypokalemia and hyponatremia. This is depleted potassium ions and depleted sodium ions. However, all of these can be overcome. Depleted potassium ions, which is hypokalemia, can be overcome by spironolactone from the collecting duct and collecting tubule. Remember from our previous slide, and therefore it's known as potassium sparing diuretics. That's the classification of spironolactones. Hyponatremia, depleted sodium ions overcome by lower water intake. Therefore, water will be retained more, sodium follows, and we're good. Increase in thirst and hypovolemia. This is decrease in our blood volume. Leads to increased ADH, which is antidiuretic hormone from the posterior pituitary gland. Okay? Hyperuricemia. It's increased uric acid in serum plasma, leading to increased deposits of uric acid in the joints, causing gouty attacks. Orthostatic hypotension is due to hypovolemia, decrease in blood volume. Hypercalcemia, as it pulls back calcium, increases calcium in the blood. Hyperglycemia, glucose intolerance and impaired insulin release. It holds back glucose into the blood as well. Thiazide-like diuretics, which is chlorthalidone, behaves like hydrochlorothiazide. Metolazone is more potent and can cause sodium excretion in advanced renal failure as well. So we've also designed a drug to be used in CKD. Indapamide, pharmacokinetics involve GI tract more than others, hence can be used in renal failures, very useful. Low doses can cause antihypertensive effects with minimal diuretic effects. So indapamide, very good drug to use. So, revision. Thiazide adverse effects, hypokalemia, hyponatremia, hypercalcemia, hyperuricemia, hypotension. Fair enough? Loop diuretics, the potent kind. Mechanism of action, major diuretic action at the ascending loop of Henle with the highest efficacy removing sodium chloride from the body. Great. But you know what else it does? It removes potassium to a very high extent. Copious amount of urine is produced and are associated with severe potency and severe side effects. Co-transport of sodium, potassium, chloride, inhibited. preventing reabsorption of these ions. Pharmacologically, it prompts the action even in patients with poor renal function. In patients with normal serum calcium levels, hypocalcemia does not occur due to calcium later being reabsorbed in the distal convoluted tubule. Otherwise, initially, calcium ions are released into the excretory tract at the loop. So it gets rid of calcium as well. So now what do we have? Just as a pointer, we have hyponatremia, hypokalemia, hypocalcemia. Increased renal blood flow is possible. Increased prostaglandin action is possible. NSAIDs, if used concomitantly, can inhibit prostaglandin, making the action of loop diuretics decrease. So NSAID and loop diuretics are inversely proportional, which means if one increases, the other decreases in its action. Therapeutic uses. It's a drug of choice for treatment of pulmonary edema or peripheral edema. So if you want a lot of water to leave the body, in cases like lung edema and body edema, that's when we use loop diuretics. It's used when edema is caused from heart failure and renal impairment. Therefore, in heart failure, we use loop diuretics. Emergency treatment of acute pulmonary edema. Useful in the treatment of hypercalcemia, as loops, they stimulate calcium excretion from the body. Useful in the treatment of hyperkalemia, as tubular secretion of potassium is also in action. Right? It's all coming back, guys. It's easy to understand now, eh? Awesome. Pharmacokinetics. It can be given oral or IV. Short duration of action, 2 to 4 hours, and problem solved. And it secretes in the urine as well. Adverse effects of loops. Ototoxicity. Causes hearing loss. Most likely due to the acid produced, ethacrynic acid. Hyperuricemia, which means loops themselves compete with uric acid to enter the renal excretion, and the loops win the race, which means it holds back uric acid. So loops try to leave, uric acid tries to leave. In that case, loops win, uric acid loses, and uric acid has to go back to the body, causing retention of uric acid in the serum, leading to gouty attacks. Acute hypovolemia, severe reduction in blood volume, can lead to hypotension, shock, and cardiac arrhythmias. That's our next lecture, by the way, guys. Hypokalemia can be caused, and hypomagnesemia can be caused. Overcome by potassium-sparing diuretics such as spironolactone, acting at the collecting duct and collecting tubule. Hypomagnesemia can be chronic use of loop diuretics clubbed with decrease in magnesium intake through diet. So, what are the summarized loop diuretic side effects? Ototoxicity, hearing loss, hypokalemia, hypomagnesemia, hypotension, but hyperuricemia. And this is the diagram from our previous slide as to what the effect on calcium is. Hypocalcemia. Potassium-sparing diuretics, we have the K-savers, such as spironolactone or amiloride. Mechanism of action: acts in collecting tubule, collecting duct, inhibits the sodium reabsorption, inhibits the potassium secretion. So there are two distinct mechanisms: aldosterone antagonism, sodium channel blocker. By sodium channel, it lets go of sodium. By aldosterone antagonism, it prevents the secretion of potassium. Spironolactone, for example, it fails the sodium-potassium exchange sites at the collecting tubules. Therefore, it inactivates the mediator protein that then prevents the sodium reabsorption and prevents the secretion of potassium ions into the urine. So it saves potassium. Pharmacologically, in any edema, serum levels of aldosterone are extremely high. That's why there is edema. There's retention of sodium water. But spironolactone antagonizes aldosterone. rendering retention useless. It leads to sodium and water secretion out through the urine, and eventually potassium is unaffected because the sodium-potassium exchange sites are inactivated by spironolactone. NSAIDs used concomitantly will diminish antagonistic activity. So NSAIDs are not good friends of spironolactone. Therapeutic uses as diuretics. Treatment of hepatic cirrhosis, we can use spironolactone. Edema is usually the diagnosis caused by secondary hyperaldosteronism. Treatment of nephrotic syndrome, heart failure, resistant hypertension where nothing else works, ultimately potassium sparing needs to work. Ascites. It's the accumulation of fluid in abdominal cavity as a complication of hepatic cirrhosis. So again, fluid retention, right? That's why. Polycystic ovary syndrome blocks androgen receptors and inhibits steroid synthesis, and it can be used in that treatment as well. Pharmacokinetics, it's absorbed orally, significantly bound to plasma protein, which means there's going to be an increase in its life because it's going to have a longer duration of action. Severe active metabolites created in the liver, again, increase in life, and inhibition of CYP450, CYP3A4 family of enzymes in the liver. This is important because it causes drug interactions. Again, there's a lecture of drug interactions, links right here. Adverse effects of potassium sparing, gastric upset, may induce gynecomastia in men, menstrual irregularities in women, so lots of hormonal problems. Hyperkalemia, because it decreases urine excretion of potassium, there's going to be more potassium in the blood. Hyperkalemia. Nausea, lethargy, and mental confusion can also occur. Relative changes of composition of urine, increase urinary excretion of sodium and water, but decrease urinary excretion of potassium. Then we have carbonic anhydrase inhibitors. Remember acetazolamide that affects the first stage of the entire tubular action? The mechanism of action is inhibits the carbonic anhydrase, which is an intracellular or cytoplasmic enzyme. It is also located on the proximal tubular epithelium. So it blocks this enzyme. Why is that important? Well, the normal function of carbonic anhydrase is the catalyzing reaction of carbon dioxide and water, leading to the creation of HCO3. Then ionizes the H ions and HCO3 ions into bicarbonate ions. Acetazolamide prevents that exchange of sodium for hydrogen, causing mild diuresis. So, in order for HCO3 to leave the body, the carbonic anhydrase is blocked. As an effect, sodium leaves the body, hydrogen stays in the body. Along with that, HCO3 leaves the body. Thereby, bicarbonate ions are retained in the secretory tract towards urine. Ultimately, potassium, sodium, HCO3, all are removed from the body. So, mild diuresis, not the best. Remember, it was a weak diuretic. Therapeutic uses, treatment of glaucoma. Acetazolamide decreased the production of aqueous humor and intraocular pressure. Remember, mild, weak. This is done by blocking the carbonic anhydrase in the ciliary body of the eye. Mountain sickness prophylaxis. Reduces cerebral and pulmonary edema. That prevents nausea and vomiting. So, other uses, not as much in hypertension. Pharmacokinetics. Administers orally and IV. 90% protein bound. Eliminated via urine. Very simple. Adverse effects, we have metabolic acidosis. Now, we will make an entire lecture on acidosis and alkalosis, so keep an eye out for that. There's going to be potassium depletion, renal stones, drowsiness, paresthesia, decreased excretion of ammonia, so avoid it in hepatic cirrhosis. What drug Do we want in hepatic cirrhosis? We would want potassium sparing diuretics. So these little notes can be helpful, you guys. Okay, so let's take a look at this diagram that explains the concept of carbonic anhydrase, so it's cleared in our minds once for all. See, this is the lumen, which means this is the kidney. Blood, which means this is plasma. Okay, so in the plasma, there's carbon dioxide. Carbon dioxide enters the epithelial cells of the renal tubule. Okay, when it does, normally speaking, water and carbon dioxide mix together and form H2CO3, which then through metabolism split into hydrogen ions and bicarbonate ions. Very simple. Later, that hydrogen ion gets swapped from the lumen and sodium is reabsorbed into the body cells from the kidney into the cells in exchange for hydrogen ion. Then there's some free HCO3 molecules that club with hydrogen ions to form HCO3 again, and then of course they would have water and carbon dioxide as their separate ions. Okay, perfect. But the carbonic anhydrase inhibitor, this enzyme, is blocked, and therefore these two functions are blocked. In other words, what's our goal here? Our goal is to prevent the formation of H2CO3, because if it forms, then hydrogen would love to leave and sodium would love to come inside. Therefore, preventing this prevents this. So sodium stays into the kidney's lumen, preventing reabsorption of sodium. That's all the reason why. Fair enough? Therefore, it's indirect, but it's weak diuretic as it keeps the sodium into the urine and not back into the blood. Fair enough? Great. Moving on. Carbonic anhydrase inhibitor decreases urinary excretion of nothing. It increases urinary excretion of sodium, potassium, bicarbonate, urine. Why is that? Is because it acts on the proximal convoluted tubule. The first thing to act on. Acetazolamide. Diuretics and urine composition changes. The key is that this color is thiazide diuretic, this is thiazide, this is loop diuretics, this is loop. Potassium sparing diuretics, and acetazolamide, which is carbonic anhydrase inhibitors. Okay? In volume of urine, the highest is done by loop diuretics and the least is done by potassium sparing. In calcium excretion, thiazides prevent calcium excretion. Loop diuretics promote calcium excretion into the urine, and the others do as well. Okay, what about potassium excretion? Thiazides and loops have equal potassium excretion, but the potassium sparing prevent potassium excretion. Acetazolamide carbonic anhydrase inhibitors, extremely high potassium excretion, which means that for hypokalemia, acetazolamide is the worst. In sodium excretion, thiazides of course excrete sodium. Loops have the highest potency in excretion of sodium. Potassium sparing have some ability, and acetazolamide also has some ability. But none of them decrease urinary excretion of sodium, right? All of them need to get rid of sodium. That's the main goal. So we talked about a large chunk of antihypertensive medications. And now we have beta blockers, which are OLOLs. And we talked about these extensively in our adrenergic system lecture. So please see that lecture for details. However, to cover antihypertensives, here we go. Beta adrenergic blockers. The activation of beta-1 adrenoreceptors of the heart blocked. Cardiac output reduced. Blood pressure decreased. Peripheral vascular resistance decreased. Blood pressure decreased. In the kidney, the beta-1 adrenoreceptors in the kidney deactivated. Renin reduced. Angiotensin II reduce, aldosterone, reduce, sodium water retention, reduce, blood volume, reduce, blood pressure, reduce. Look how much effect does beta blockers have on the heart and on the kidney to reduce blood pressure. Perfect. Pharmacologically speaking, it decreases cardiac output, therefore reduces blood pressure, decreases sympathetic system outflow of the CNS, inhibits release of renin in the kidneys, decreases angiotensin II formation as a result, decreases aldosterone secretion, and nebivolol is selective beta-1 blocker that increases nitric acid production. It's a very important point that which beta blocker in the antihypertensive classification causes increase in nitric acid production? Vasodilation, right? Remember, nitroglycerin or nitrosedation, all of this causes vasodilation, hence reduction in blood pressure. Propranolol is a non-selective beta blocker, which are actually contraindicated in hypertensive patients with asthma because bronchodilation mediated by beta 2 blockage. What does that mean? Well, think of it this way. If propranolol is non-selective, then it will also block beta 2, right? So beta 2 is blocked. What's the job of beta 2? Beta 2's job is to create bronchodilation. Okay? Beta 2's job is to create bronchodilation in patients with asthma. That's why, if you remember, we have treatment of asthma, we have beta 2 agonist, right? But if propranolol, being a non-selective, blocks beta 1 and beta 2, then there will be bronchoconstriction. And what does bronchoconstriction do? Cause asthma. Therefore, if there is a patient with hypertension and asthma, then we avoid beta blockers, such as propranolol, which are non-selective, beta 2 as well. So we want nebivolol, which is beta 1 blocker. Fair enough? Okay, in therapeutic uses, it's for treatment of hypertension with concomitant diseases as well. Treatment of supraventricular tachyarrhythmia, beta blockers, again, antiarrhythmetics or antiarrhythmetic drugs, we have beta blockers as a classification. History of MI, angina, and chronic heart failure, beta blockers, very useful. What are the adverse effects then? It precipitates asthma when used in hypertensive patients who are also diagnosed with asthma when beta 2 and beta 1 non-selective beta blockers are used. Very important to remember. It can lead to bradycardia, hypotension, fatigue, lethargy, insomnia when it's too much active. It decreases libido and erectile dysfunction as well. It increases triglycerides and decreases HDL. Therefore, lipid metabolism is disturbed, leading to increase in cholesterolemia in the blood. MI, angina, and death in IHD patients will abrupt withdrawals of these drugs. So it can precipitate, beta blockers can precipitate MI, angina, and death in IHD patients that have abrupt withdrawal. So if you're withdrawing beta blockers, we need to taper the dose. Taper the dose. Slowly, gradually. So what are the side effects of beta blockers? We got hypotension, bradycardia, fatigue, sexual dysfunction, insomnia. Angiotensin converting enzyme inhibitors, the new class now, ACE. So remember, as soon as we hear this, remember that ACE was the one that converted angiotensin 1 to angiotensin 2, the low active to powerful, packed, active, updated 2.0 model, right? So angiotensinogen, the inactive, is just swimming around in the blood, and then renin comes along that converts angiotensin 1. It's still inactive, right? Not so active. Angiotensin 2 is now formed by ACE's help. This is normal function, ACE, angiotensin converting enzyme. which then causes aldosterone production, which would then affect increase in blood pressure. However, if you think about it in the perspective of this chart, angiotensinogen is formed. Renin leads to angiotensin 1 production, and ACE is blocked by ACE inhibitors. Remember the ACE inhibitors? Prils, enalapril, captopril, and so on. They block this step. Therefore, angiotensin 2 not formed. Therefore, aldosterone production not formed. That leads to decrease in the sympathetic nervous system, decrease in the retention of sodium water, increase in vasodilation. Essentially, it decreases blood pressure. Other group of drugs are renin inhibitors that are also mentioned here. Renin inhibitor prevents angiotensin 1 formation altogether, hence none of these take place, therefore blood pressure reduces. Then the other drugs are angiotensin receptor blockers. That lets angiotensinogen to be angiotensin 1, angiotensin 1 to become angiotensin 2, but this may be active, but it will just freely float in the blood. There will be no receptors to act on it. Aldosterone production stopped and decrease in blood pressure. Fair enough? That's what these are. Okay, moving on. ACE inhibitors. We got all the prils. Captopril, enalapril, very commonly known. Captopril side effects. This is very easy to remember acronym, captopril. It can cause cough, angioedema, agranulocytosis. Very, very important to remember. Proteinuria, so protein is left in the urine. Taste changes, orthostatic hypotension, obviously too much of it. Pregnancy contraindication, so do not use captopril in a pregnant patient. Renal artery stenosis contraindication, do not use in a patient with renal artery stenosis. Increase in renin, that's what it will lead to. Leukoplakia and liver toxicity. So a cause of leukoplakia is captopril. Who knew, right? Okay, moving on. ACE inhibitors, details. Pharmacological action. Decrease blood pressure, simple, by decreasing the PVR without affecting cardiac output, heart rate, contractility. So remember the formula? BP equals CO times PVR. Well, ACE inhibitors only act here. That's it. Has nothing to do with cardiac output. PVR only. Okay. It blocks the ACE enzyme responsible for converting the angiotensin 1 to angiotensin 2. On the other hand, ACE will also break down bradykinin, which is responsible for the production of nitric oxide and prostaglandins, which are potent vasodilators. Okay, so we've introduced a new concept about bradykinins, okay? I will make sure to explain this in the next slide, so stay hanging to it. But because the ACE inhibitors block ACE, they protect bradykinin, allowing the production of nitric acid and prostaglandins. Fair enough? Summary: decreases vasoconstriction by blocking angiotensin 2, increasing vasodilation by blocking the breakdown of bradykinin. Okay, if this is really hard to understand right now, that's okay. I will make sure I explain it in the next slide very diligently. Indirectly, it reduces aldosterone, leading to decreased sodium water retention, therefore reduces afterload, preload, cardiac output. In the therapeutic uses, the treatment of hypertension, treatment of diabetic nephropathy, efferent arterial vasodilation on kidneys leading to decreased GFR, improving renal functions. Standard of care for MI patients is ACE inhibitors. First line drug treating congestive heart failure, systolic dysfunctions, CKD with hypertension, and high-risk patients for coronary artery disease. Treatment of ventricular hypertrophy. Very, very useful drug, and that's why, remember, ACE inhibitors were used in all of the heart diseases concomitant with hypertension. Pharmacokinetics. Orally bioavailable, all ACE inhibitors except captopril and lisinopril undergo liver metabolism, and therefore these are preferred in hepatic impairment. So if there's a person with hepatic impairment and hypertension, then use captopril, lisinopril, because they don't go through liver metabolism. There are active metabolites of other ACE inhibitors as well, so it's pretty potent. Adverse effects, dry cough. This is the link to bradykinin. Okay? Again, I'll explain this in just a second, so hold on to the thought. It's corrected by the use of ARBs. Next slide. So if there's a patient with dry cough due to the use of ACE inhibitors, then we use ARBs. And that's the next classification of the drug, the sartans. Remember the sartans? Okay. Other side effects are rash, fever, altered taste, hypotension, hypovolemia, hyperkalemia, increase of potassium in the blood. Rarely it's life-threatening, angioedema. Remember, it has to do with the skin and blood disorder. Serum creatine levels monitored, and fetal malformations in pregnant women, so avoided in pregnant women. So dry cough, hyperkalemia, skin rash, and hypotension. Angioedema, good to remember for this group of drugs. Okay, so here it is. Finally, the suspense of bradykinin. ACE inhibitors can cause dry cough in 10% of the users, and it's a big side effect. Bradykinin is a molecule. Through ACE, it becomes inactive. That's normal. What does bradykinin do? Bradykinin normally produces nitric oxide and prostaglandins. Normally. It produces that normally. And that leads to vasodilation. Okay? That leads to vasodilation, normally. But in the presence of ACE, all of this is inactivated. However, if we use bradykinins along with ACE inhibitors, then ACE inhibitors prevent the breakdown of bradykinin. Therefore, bradykinins will be increased in quantity, correct? And thereby there will be increased production of nitric oxide and prostaglandin. And therefore there is increased vasodilation. It's great because along with ACE inhibitors preventing the angiotensin 1 to be converted to angiotensin 2, it also acts on bradykinin, leading to vasodilation, decreasing the blood pressure. That's perfect. But there's also increased leukotrienes and histamines, and that leads to coughing. Therefore, in the treatment of asthma, we have leukotrienes inhibitors such as montelukast, so that the coughing is prevented. There is a prevention of leukotrienes leading to prevention of coughing in the treatment of asthma using montelukast. That's why leukotrienes cause cough. Okay, here's another chart. Bradykinin through ACE would be inactive, but through ACE inhibition, that pathway is blocked. And therefore, there is increase in prostaglandin, increase in leukotrienes, increase in histamine. All of that leads to increase in cough. Very, very simple. Perfect? That's why ACE inhibitors and bradykinin are a cough issue. So, to prevent that, we will block angiotensin 2 receptor blockers, ARBs. Alternatives to ACE inhibitors for patients who have cough issues. ARBs inhibit angiotensin receptor type 1, leading to decreased activation of the receptors by angiotensin 2, which normally happens. So angiotensin 2, it gets created, it's perfect, but it just floats around. It cannot attach itself to this receptor, and therefore no activity. So functionally speaking, there is venous and arterial dilation. It blocks aldosterone secretion, It decreases blood pressure, it decreases sodium-water retention, decreases blood volume, and so on and forth. Along with that, ARBs prevent the side effect of coughing, dry cough, because bradykinin is out of the equation. It's done by skipping the steps blocking ACE. So if ACE is not blocked, then bradykinin will follow its normal fate of being metabolized, broken down into inactive peptides, and the build of unwanted bradykinin will be inhibited. Therefore, no leukotriene activation above normal values, therefore preventing cough as well as angioedema. So, ARBs are better than ACE when it comes to bradykinin function. Therefore, it's a first-line treatment of hypertension, CHF, and CKD concomitant. Adversely, ARBs are teratogenic and are not to be used by pregnant women. So contraindicated, it's teratogenic. Then comes renin inhibitors. Aliskiren, very selective renin inhibitor. So first step of RAS, blocked. It acts at very early in RAS, creates both ARB and ACE inhibitor action to treat hypertension. The whole process is blocked. Essentially, it lowers the BP by vasodilation, decreasing cardiac output, decreasing the PVR, decreasing the blood volume, by reduction in sodium-water retention. And all of that happens just by aliskiren. Side effects: diarrhea, cough, angioedema. Contraindication: pregnancy. Metabolism: liver, CYP3A4 family. Therefore, drug interaction is anticipated. Must be used in conjunction with other drugs such as thiazides for treatment of hypertension. So, here is the whole summary. Normal RAS function. Okay, so the next 3 slides, guys, pay very, very close attention. I know this has been a long lecture, but you guys have been doing great. So stay with me here. Normal RAS function. Angiotensinogen, inactive molecule. Through renin, becomes angiotensin 1, still inactive. Angiotensin 2 is formed as soon as angiotensin converting enzyme steps into the play, and now we have a power-packed second model active molecule of angiotensin 2. Angiotensin 2 has 3 effects: aldosterone production, vasoconstriction of blood vessels, and increase in sympathetic tone, CO, and PVR. Overall, aldosterone increases sodium-water retention and therefore increases blood pressure. Vasoconstriction directly increases blood pressure. Increase in sympathetic tone, cardiac output, and peripheral vascular resistance increases direct blood pressure. ACE prevents coughing. How? Well, bradykinin is, because of ACE, bradykinin becomes inactive. Therefore, excessive bradykinin is prevented. Therefore, cough is prevented. That's normal RAS function. No coughing, increased sodium-water retention, vasoconstrictor increase in CO, and increased blood pressure. This is basic RAS. But renin inhibitors block this step right here, angiotensinogen to angiotensin 1. Therefore, the whole system is blocked. Therefore, cough is present, decreased sodium-water retention, vasodilation, decreased cardiac output, decreased blood pressure, all of that occurs. ACE inhibitor pathways allows for angiotensinogen to become angiotensin 1 through renin. It's good, no problem. But the enzyme, angiotensin converting enzyme, is blocked. Therefore, angiotensin 2 cannot be formed, and therefore the whole process is blocked. But there's coughing, because angiotensin converting enzyme will block bradykinin from being metabolized. Therefore, bradykinin remains active. It increases in its quantity, leading to increase in leukotrienes, causing cough. However, there's still decrease in sodium-water retention, decrease in the vasoconstriction, lead to vasodilation, decrease in cardiac output, decrease in blood pressure. So it's an antihypertensive medication. What about ARB pathways? First step, allowed. Second step, allowed. But it blocks the ARBs, the angiotensin receptor blockers, the AT1 receptors. Therefore, there is a blockage of aldosterone activity. But the angiotensin 2 enzyme, the angiotensin 2 activity on vascular smooth muscle and sympathetic nervous system is activated. Therefore, blood pressure can still increase via heart and blood vessels. Okay, so kidney is blocked, heart and blood vessels still activated. Therefore, ARBs have to be used in conjunction with other diuretics such as thiazides. That helps decrease blood pressure. And again, ACE is available, therefore bradykinin will metabolize into inactive peptides and no cough will occur. So no coughing with ARBs, decrease in sodium water retention, decrease in BP, but heart and blood vessels still active. Hopefully these charts helped you guys understand the whole process, and this chart we went through earlier. So feel free to pause here and write down the whole chart for yourself as well. We've been through a lot of details for RAS system. Now comes the next group of antihypertensive, which is calcium channel blockers. It's recommended treatment for hypertension patients with diabetes and angina, but not for stroke. Okay, we do not use calcium channel blockers for stroke or treating hypertension. However, as a rule, high dose of short-acting calcium channel blockers must be avoided to prevent MI due to excessive vasodilation, causing a reflex cardiac stimulation, and balance must be maintained. Right, so for example, if calcium channel blockers cause excessive vasodilation, our brain goes, oh, I need to reflex. So the cardiac muscle stimulates itself and cause vasoconstriction. And that may lead to MI itself. So short-acting, high-dose CCBs prevented. Okay. Now there are three types. This is diphenylalkylamines, which is verapamil. There's dihydropyridines, which is nifedipine, amlodipine, nicardipine, all the dipines. And there's benzothiazepines, which is diltiazem. What's the difference? Well, the diphenylalkylamines, the verapamils, are least selective, but significantly affecting both cardiac and vascular smooth muscle. However, our focus mainly with verapamil is blood vessels. Treatment of angina, supraventricular tachyarrhythmia is done by verapamil, calcium channel blockers, used to prevent migraine and cluster headaches. The diltiazem is also used to treat cardiac muscles and vascular smooth muscles while overcoming the negative inotropic effects of the heart. Greater affinity for heart than blood vessels, so this has to do with heart. Okay, verapamil causes increased contraction forces on the heart, while diltiazem controls that aspect. Okay, what does that statement mean? See, a lot of it has to do with heart activity. So think of it this way: calcium is excessively used to produce a heartbeat, correct? So if we block that calcium, then the cardiac muscles will be relaxed, blood vessels will be relaxed, and that will lead to vasodilation. Now, the difference between verapamil and diltiazem is that verapamil affects blood vessels itself. Okay? Diltiazem, it treats cardiac muscles by overcoming negative inotropic effects. Inotropic means to produce a shock in the SA node of the heart. Okay, it overcomes that. It relaxes it. Therefore, there is a greater affinity for diltiazem on the heart itself. Verapamil causes increased contraction. So verapamil causes increase in SA node contraction, while diltiazem controls that. So depending on the cause of the concomitant disease, we can prescribe either verapamil or diltiazem. Then comes nifedipine, amlodipine, nicardipine, and so on. That group has a greater affinity for smooth muscles, which is vessels, blood vessels, in the calcium channels on those blood vessels, as compared to the cardiac muscles. Very desirable action for treating hypertension, right? And it can cause drug interactions when there is use of digoxin and warfarin as well. So calcium channel blockers with all the dipins, diltiazem, other dipins, and verapamil have different effects. So dilation of coronary vessels, nifedipine and diltiazem have a strong action causing vasodilation. AV conduction, so it's how the heart conducts itself. Nifedipine has nothing to do with it because it has a blood vessel effect. However, verapamil has a huge effect on the conduction of the heart contraction, and diltiazem has less effect on that property of the heart. Frequency of adverse effects, nifedipine highest. Which one? Calcium channel blockers is gingival growth, overgrowth, known as DIGO. Drug-induced gingival overgrowth caused by calcium channel blockers, nifedipine. Fair enough? Okay. Pharmacological actions. Calcium is essential for ionotropy of the cardiac muscle, as well as the muscle tone of smooth muscles of the vascular structures, which is blood vessels. The heart contracts on command of the calcium. So, calcium enters the voltage channels and into the cardiac muscle, causes a positive feedback cycle for calcium, continuing to enter the muscle. That leads to a heartbeat, a pulse rate, but the CCBs prevent this influx of calcium into the vasculature. This relaxes the vascular smooth muscles, relaxing the arteries. Therefore, CCBs do not dilate any veins. It has to do with arteries. In order to dilate veins, we have vasodilators that are available, and we'll talk about that in the next slide. Therapeutic uses. Treatment of hypertension. Such patients with asthma, diabetes, peripheral vascular diseases can use calcium channel blockers. But notice how it has nothing to do with the cerebrovascular accident, also known as stroke. Remember that point, guys. Unlike beta blockers, calcium channel blockers present no harm to asthmatic patients facing hypertension, so it can be used. Treatment of angina and atrial fibrillation or arrhythmias can also be done by calcium channel blockers. Arrhythmias are next lecture, guys. Adverse effects of calcium channel blockers. Atrioventricular blockage, constipation, very common, of verapamil. Right? Remember, it has to do with AV node, SA node. So atrioventricular conduction is blocked by verapamil. Avoid calcium channel blockers in patients with congestive heart failure and patients with negative inotropic, which is less force of contraction. So avoid it because they already have less calcium effect. Why cause even more less effects, right? And dromotrophic, which is less velocity of the heart, also known as the chronotrophy of the heart. So when there is less blood flow through the heart, when there is less heartbeat formation, why create even less? Therefore, we need to avoid calcium channel blockers in congestive heart failure. It can cause dizziness, headache, fatigue due to decreased blood pressure. It's common with amlodipine. Peripheral edema, also common. Most popular side effect of nifedipine is gingival hyperplasia. So we got flushing, headache, dizziness, hypotension, peripheral edema, and DIGO. Very, very important, guys. Here are some DIGO pictures. So these are not a disease caused by periodontal issues. It's actually drug-induced gingival overgrowth. It can lead to plaque retention, plaque accumulation, lack of cleanliness, and lead to gingivitis. Then comes alpha-adrenergic blockers. Alpha blockers, such as zosins, doxazosine, prazosin, terazosin, they completely block alpha-1 receptors. And where do alpha-1 act? On vessels. So primary goal of activation of alpha-1 is vasoconstriction. We know that. Naturally, blocking that alpha-1 leads to vasodilation, causing decreased peripheral vascular resistance and eventually reducing blood pressure. This is done physiologically done by relaxation of both arterial venous smooth muscles. However, less effect on actual cardiac output of the heart. Renal blood flow and GFR less effective. Therefore, beta receptors such as on the heart and on the kidney have to be blocked. Therefore, a drug that is beta-1 blocker and alpha-1 blocker is best. Correct? Keep that in mind. We'll come back to that concept in just a second. Reflex tachycardia and postural hypotension can occur, two extremes of the spectrum, and is often observed with initially phase of alpha blocking treatments. The body says, oh, why is my heart rate dropping so much? Let me reflex it and shock the heart. Or if the blood pressure is dropping too much, it's going to be even deeper drop in blood pressure, leading to postural hypotension. Not used for initial treatment of hypertension because of this reason, but used for refractory hypertension, which means if nothing else works, this will work. That's what it means. Now, remember we were talking about alpha-1 blocker and beta-1 blocker? Well, that's where the alols come, labetalol and carvedilol. They block both alpha-1 and beta-1 receptors. Labetalol, carvedilol are alpha and beta adrenergic blockers. They block both alpha-1 and beta-1. Along with it, it blocks beta-2 as well. Labetalol is used for the treatment of gestational hypertension and hypertensive emergency patients. Gestational means during pregnancy. Carvedilol is used for the treatment of hypertension as an adjunct and in the treatment of congestive heart failure. Metoprolol, succinate, and bisoprolol have also shown to reduce morbidity and mortality associated with heart failure. So hypertension, congestive heart failure, we can use alpha-1, beta-1 blockers. So alpha-1, it decreases the vasoconstriction, leading to vasodilation, leading to decreased heart work. Beta-1 receptor blockers decrease in the force of the heart, leading to decrease in the heart work. That causes vasodilation and decreased cardiac output. Then comes centrally acting adrenergic drugs. This was under the other category, if you remember from the classification earlier. We got clonidine and methyl-dopa. Remember we said if you don't remember the whole thing, no problem. It's very important to remember clonidine and methyl-dopa. Clonidine is alpha-2 agonist. Now, to understand this, we have to go back to our sympathetic nervous system, adrenergic system lecture. However, I'll tell you what alpha-2 does. Alpha-2 prevents norepinephrine action. That's the summary of it. How? Please check out our lecture for the adrenergic system. So alpha-2 agonist prevents even more norepinephrine. Therefore, it inhibits sympathetic pathway, reduces norepinephrine concentration in the synapse, therefore decreases PVR and cardiac output, and decreases blood pressure. Perfect? In other words, it increases reuptake. Write this down, guys. It increases reuptake of norepinephrine in presynapse. Therefore, norepinephrine cannot cross, and therefore a inhibition of sympathetic pathway occurs, and blood pressure eventually reduces. Refractory hypertension treatment can be dealt with clonidine. It does not affect GFR, not renal blood flow, therefore it's useful in treatment with kidney impaired function, CKD patients with hypertension. Side effects include sedation, dry mouth, constipation. Methyl-dopa, also alpha-2 agonist, converts to methyl norepinephrine centrally in the CNS. This basically diminishes adrenergic flow of the CNS, reduces it, Therefore, side effects are sedation and drowsiness because it occurs in the CNS. Treatment of hypertension in pregnancy is the main use. So if somebody asks, how do you treat hypertension with pregnancy? Your answer should be methyl-dopa. However, the side effects are sedation and drowsiness. How does it act? It acts as an alpha-2 agonist. Fair enough? Perfect. Let's move on. This is the diagram to explain what alpha-2 does. So regardless, please do check out our video on adrenergic system. So here it is. Clonidine is used in the treatment of hypertension as it decreases norepinephrine release, leading to decreased activation of epinephrine at the target tissue. Beautiful? The decrease in the release of norepinephrine from presynaptic vesicles helps prevent norepinephrine toxicity to control the postsynaptic activity. So normally alpha-2 is good. It prevents the toxicity of norepinephrine, but clonidine hyperactivates alpha-2. It's an agonist of alpha-2. So what happens? See, alpha-2 receptors, activation of the receptor decreases production of CAMP, leading to inhibition of further release of norepinephrine. Okay? Clonidine hyperactivates this, which means all the norepinephrine goes in and goes all the way up there and nothing reaches the target tissue. So alpha-1 receptors, activation of alpha-1 increases production of molecules that lead to increase in intracellular calcium ions. So normally, what would have happened is norepinephrine would attach to alpha-1. Alpha-1 would create increase in calcium. That would create increase in cardiac output, increase in blood pressure, increase in PVR, and so on and forth. It's perfect. However, alpha-2 prevents all of this, takes the norepinephrine back into its house, leading to decrease in cardiac output, decrease in blood pressure, decrease in PVR. Fair enough? That's the mechanism. Now come direct vasodilators. Okay. Hydralazine and minoxidil are the two drugs that are direct vasodilators. They're primary vasodilators, but not used in the treatment for hypertension primarily. These drugs only relax vascular smooth muscles, not on the heart, just the vessels. Eventually, it leads to decrease in peripheral vascular resistance, and eventually blood pressure reduces. The reflex stimulation of the heart can occur, right? Because if everything drops so much, the heart and the brain goes, uh-oh, let's increase the myocardial contractility. That increases the heart rate. It prompts angina pectoris, MI, and heart failure because of it. Therefore, concomitant use of beta blockers is important to prevent the reflex. Increase in plasma renin can also occur. Okay, so vasodilators can also lead to increase in plasma renin. That increases aldosterone, that increases sodium water retention. Therefore, concomitant use of diuretics is also important. Okay, so beta blockers need to be used to treat reflex tachycardia. Okay, diuretics need to be used to help the treatment of increase in renin. All of these need to be used with direct vasodilators such as hydralazine and minoxidil. So accepted combination treatment of hypertension is hydralazine, which is a vasodilator, propranolol, which is a beta blocker, and thiazide, which is a diuretic. Right? So V, B, D must be used together if you're choosing to use direct vasodilators. Minoxidil fact, it causes hypertrichosis, which is hair growth treatment for male pattern baldness. Hydralazine side effects, reflex tachycardia, headache, anginal precipitation, and lupus-like syndrome. Okay? And hypertensive emergency. We're nearing the end of the lecture, guys, so thank you for staying with us. You guys are doing great. Thank you. Hypertensive emergency is rare, but it's life-threatening. Characteristics are severe elevation of blood pressure, which is Systolic above 180, diastolic above 120. So 180 over 120 and even more. Evidence of impending progressive target organ damage is seen with concomitant diseases such as stroke that breaks the blood flow or increases blood flow into the brain. MI is in the coronary arteries. If there is severe elevation of blood pressure but no evidence of organ damage, so no MI or stroke, then this is not hypertension emergency. It's actually known as hypertension urgency. However, even in this case, blood pressure 180 over 120 needs to be present. The treatment modalities for emergency of hypertension. We can use calcium channel blockers, the DIPINs, nitric oxide vasodilators such as nitroglycerin, adrenergic antagonists or beta-alpha blockers, right? Alpha blocker, beta blocker, vasodilator like hydralazine. Remember, but with hydralazine, we must use vasodilators, beta blockers, and diuretics together. Dopamine agonist, which is phenol-dopam. This is from our CNS series, so please check out our lecture in CNS as well, guys. Our references for today are in the description box below, but we used the Guyton and Hall textbook of physiology and Lippincott for pharmacology to produce this lecture. Thank you for watching, and thank you for staying in such a long lecture with us. You guys are doing great, and for more amazing academic lectures, please stay with us, like, share, and subscribe, and spread the word that Tooth Factory is in town. Thank you very much. Have a great day.